Joining. Okay, just after 4 o'clock here in Southeast Queensland, Australia, and 9 a.m. in Israel. Other times for other people joining from Australia and elsewhere. Welcome to the Australia-Israel Scholar Seminar Series. This is actually our 25th talk and the final talk of this season. We'll probably pick up again in a month or two or three, because there was a lot of interest around these talks. Before we go, I'd just like that we acknowledge the traditional owners of the land. This is a land where I am here in Southeast Queensland. These are the Jagera people and the Turrbal people. They're the traditional custodians of the land on which we gather today, on which I am on. We pay respects to their elders past and present. We extend that respect to Aboriginal and Torres Strait Islander people here today. Now, actually, for me, it's a huge pleasure to introduce Associate Professor Pavel Goldstein, Associate Professor, right? At this point, yes.
Recently.
Recently, congratulations. The reason that it's a huge pleasure is it's very selfish, and of course, my selfish story should not kind of hide his stellar CV. I just had the pleasure of having Pavel as an undergrad student in a class that I was lecturing into while I was doing PhD. And he certainly stood out. And since then, he's had a stellar career around the world, and then came back to Israel and has built the eye pain lab at the University of Haifa, dealing with a very important subject that all of us feel today. And unfortunately, some that don't feel it today might feel it tomorrow. Let's see. Well, thank you very much, Pavel, for this talk, and looking forward to hear what you have to say. Thanks.
Thanks, Yoni. Very kind of you. And the same here. It's my pleasure to be here. And definitely, I was very inspired by you as my teacher, one of my first teachers, lectures. So basically today, running integrative pain lab, I also leading a new program in biostatistics. So, I'm kind of continue to be on bus paths. Today I think we will focus on chronic pain. So I think this is kind of my main thing that I am doing, and I would love to share with you a new perspectives on chronic pain. And hopefully it will help you also to understand and maybe even to heal chronic pain. That also happens sometimes. So let's start. Okay, I think we will, first of all, I want to show you where I'm from. So this is Israel, Haifa, and University of Haifa. This is a view on the university, and you see the view on the sea. It's very beautiful. And this is my lab, integrative pain lab. So we have postdocs, PhD students, undergraduates, master students, and all of us were working together to help people with chronic pain. And basically, we are doing some computational work, developing new ways of diagnosing chronic pain using different technological approaches. And also we developed a new therapeutic approach, and today I mostly will focus on this one. But before we start, I suggest we'll run a short experiment. I will ask you to pinch yourself. Let's do it gently, but on the same time, I want you to feel this unpleasant sensation that we call pain. Okay, please do it. Yoni, show us. Example, great. And pain around 3 and 4 on scale from 0 to 10, that will be great. And let's see what just happened. Okay, in our body, we have very special sensors that detect a mechanical damage to our body, right? And it sends signals through our spine to our brain. And in the brain, we have very comprehensive processing. You see, we don't have one region of pain. We have huge network of regions that work together. And basically, at the end, we'll feel pain at some level. And this is really a very comprehensive decision based on many, many factors. And what I want to say you basically is that pain is interpretation of our brain based on all this comprehensive process that take into account our emotional state, our expectations, environment, right? So if I see around me a beautiful woman, I guess my kind of expression of pain will be different than in some different settings, right? Yeah, so basically what I want to say, pain protects us. It's alarm system that protect us from external damage and also internal damage, like for example, in the case of appendicitis, right? But in some cases, pain can stuck and become persistent. And that's what happened to around 30% of Americans. I'm talking about Americans because NIH really good in creating these infographics. So you can see here the map of America, and on the map you see basically the frequency, the prevalence of chronic pain comparing to three other frequent conditions such as cancer, heart diseases, and diabetes. And as you can see, chronic pain is more persistent than three of them together. And of course, if you're talking about US, we can also mention opioid crisis that takes around 220 lives daily in the United States today. So you're here in Australia. So for Australia, you have a bit less prevalence, around 20% of chronic pain, but it also depends how we measure it. So it's pretty much the same. And now I want to basically to go with you through the process of diagnosing chronic pain and treating chronic pain using biomedical model of pain. So this is the model that our healthcare system, Western healthcare system, use to diagnose and treat chronic pain. So how we diagnose chronic pain? Basically, biomedical model of pain says, okay, if you have your pain in your knees, we will diagnose and treat your knees. If you have your pain in your back, we'll diagnose and treat your back, right? So basically, we're talking about localization of pain. And here, let's take a very more specific example of back pain. And we have a very important assumption here. If we find a damage in our back, we say this is a cause of our pain, right? So when you come to a doctor, it says you to imaging, right? So you have this imaging, and if doctor find something wrong, anatomically wrong in your body, he says, okay, this is the cause of your pain. So let's firstly try to examine this assumption and to see if it's really valid. Okay, so mostly, as I said, we examine people who have pain, right? You come to a doctor and you send to this scan. But what about people who doesn't have pain? So we have several studies who focused on this matter. So in this study, the researchers they took people without any pain, no pain at all, but they still send them to the scanning. And as you can see here, so maybe it will be surprising for some of you, many of these people have some abnormalities in their back, like disc degeneration, a loss of signal, and many other, it's not conditions, but basically symptoms, right? Okay, but they don't have any pain. So here, I think we can say, hey, like maybe this kind of assumption that anatomical abnormalities in our body and pain, it's not really so valid. And more than this, specifically in case of back pain, 80% of people who basically have back pain, they get very interesting diagnosis that called non-specific low back pain. What it means that the doctors don't find any abnormalities in their back. So basically, only 2 to 3% of people with pain have really structural issues, some abnormalities that cause their pain. Okay, so that was about diagnostics. What about treatment? So what we use today to treat chronic pain in Israel is very frequently used epidural injections. I don't know how it's frequent in Australia, but today many studies show that basically it have placebo effect. In our lab, during my postdoc, we ran a study where we used saline, just injecting saline instead of epidural, and we got exactly the same results as just using epidural. So this is about placebo, right? When you say placebo, it doesn't mean it has zero effect, but basically this is about the mechanism that underlies this treatment. It's different. Opioids. So it's also surprising also to hear that opioids, they also work as placebo. And actually, I think the most famous studies that published in this case, it comes from Australia. Different spine stimulations, also placebo. Medical cannabis, no clinically significant evidence that really it works. Correction surgeries that actually run a lot today in all Western countries, and it's really disaster. They basically have placebo effect. So why this biomedical approach is still here? You can ask me, right? No, so basically I think it's pretty simple. It makes sense for clinician. We have very simplistic mechanistic explanation about pain using biomedical approach. It's very intuitive. It makes sense also for the same reason it makes sense for the patient, right? So they basically sync with this explanation. It's very easy to communicate around this model. Very easy to justify the mechanism. Okay, yeah, you found some abnormalities in your back, and this is the reason of pain, right? It's very simple and it makes sense. And we have a very clear business model around it. So basically send people for diagnostics, we give them any different biomedical treatments to help them, basically to manage their pain. Okay, so, but I think you will agree with me that this model doesn't work. We have a lot of evidence today for this. So if it doesn't work, well, basically how we can try maybe to look for something different and where we should look for. So if you remember on one of my first slides, I showed you the brain. You remember this pain matrix, how we called it? Okay, this network that analyzes different signals to understand how much pain we will feel, or basically to create this pain. So let's try to look at the brain. So this is an MRI scan of a person with who just undergo, for example, pinching. Okay, just got some injury. So this is about acute pain. Okay, that was basically this is the pattern that you will see in your brain when you was pinched or you pinched yourself in your case, right? So this is just a very common pain matrix. And this is how brain react to chronic pain, spontaneous chronic pain. You don't need to be a neuroscientist to see the difference between those two pictures, right? So you clearly see that they are different. So basically what I want to say is that acute pain and chronic pain, they have completely different neurophysiological patterns. And in the case of chronic pain, we see activation in our prefrontal cortex, and more specifically, emotional center of our prefrontal cortex. Our prefrontal cortex is responsible for decision making. Basically, this is the only region in our brain where lives our awareness. We are aware of different processes through our prefrontal cortex. And we process also emotions. We are aware of our different emotions. So basically, this is activation that we see. Why? Why basically emotional awareness responsible for chronic pain? And why we don't see all this classical activation of pain matrix that we see on the left? Okay. Basically, the response or the answer is neuroplasticity. Did you hear about neuroplasticity? What is neuroplasticity? Yeah, well, so neuroplasticity, it's a feature of our brain. It's not about good or bad, it's just a feature. Our brain learns, it always learns. And neuroplasticity is basically the changes in our brain. We create new paths, some of the old paths disappear if there is no need. And this is exactly the neuroplasticity. How we create new pathways in our brain to create new functions, new features, to learn something. So basically, as we understand today, neuroplasticity is also responsible for creating chronic pain. So here you can see communication between prefrontal cortex and one of the very important regions called amygdala. Amygdala, this is a region responsible for alerting us about the danger, potential danger. Okay, when kind of we see potential danger, amygdala send a signal, I will play it one more time, to our prefrontal cortex, and it say, hey, this is danger, okay, so basically take responsibility and do something about it. And as you remember, I said potential danger. It doesn't mean we're in danger. Basically, just a very quick reflection. For example, you see a mouse, right, or a spider, and you're afraid of it, and the amygdala still will send the signal to our prefrontal cortex and say, hey, there is a danger. But we understand that in this case, it's not really dangerous, right? So this is very evolutionary process. And all this region played a really important role for us millions of years ago when we really lived in danger. But today, basically, it's much more comprehensive. As we understand today, amygdala may send these false alarms in many cases and convince our prefrontal cortex that we are in danger. Now, how brain will alert us that we are in danger? This is pain. This is exactly the pain. Pain, this is a signal that comes to alert us if something wrong, if there is a danger to our body. And if it happens frequently, neuroplasticity may play his role, and it create a new pathway between amygdala and prefrontal cortex, and this path will constantly create pain without any reasons in our body. So, to summarize it, we have this process of communication between amygdala and prefrontal cortex, and if this process happens long enough, neuroplasticity will straighten this pathway and will create a new kind of chronic pain that we called nociplastic chronic pain or neuroplastic chronic pain because it happened as a result of neuroplasticity. So nociplastic, neuroplastic chronic pain. And this is the most frequent kind of chronic pain. We see it in all musculoskeletal conditions like back pain, neck pain, knees, and many others, fibromyalgia, IBS, headaches, phantom pain, CRPS, endometriosis, and many other conditions that you know maybe about your family, friends, and maybe you don't know actually, because actually we call to chronic pain hidden condition because people not frequently communicate about it. So, to summarize it, if we talk, for example, about a situation where we have an injury, for example, a car accident, we may have a real pain, right? We have a real damage, and our body sends a signal to the brain, and we feel pain. But after several months, our body recovers. 3 to 6 months, our body recovers. But because of the neuroplasticity, this pattern of creating the pain, okay, feeling the pain may still stay. So basically, we get to the situation where we don't have any activation in our body that sends a signal to the brain, but the brain just generates the pain, this nociplastic, neuroplastic pain. So, what could be the solution? So, as we said, brain here play the main role in creating this pain. So maybe we can use the same process of neuroplasticity to eliminate this pain. And that's what we did. We created a new therapeutic approach that called PDSR, Personalized Danger Signal Reprocessing. And this is my collaboration with a coach, Yulia Zatulovsky. So we create a therapeutic approach that we run in Zoom, and we run it as a group therapy for 8 weeks, 16 hours. We have intensive chat support and also self-training. What we are doing? As you remember, pain is interpretation of our brain, and interpretation we can change. So our first tool, we are using what's called psychoeducation. And that's exactly what I'm doing with you today. So there is a lot of studies that shows just psychoeducation, basically understanding how brain works, like kind of getting awareness about pain processing, may stop, eliminate, or at least reduce the pain. Another very important feature, we are running different coaching techniques to convince the brain that he is not in danger. You remember pain, the signal of danger. So basically he convinced that he is in danger, and he just tried to say, hey, we're in danger. And the pain is just basically alert you that you're in danger. If we convince the brain that you are not in danger, the pain stops because there is no need. And of course, the main difference between our approach and what you another classical biomedical approaches, we are trying to heal the pain. We are not managing pain. Healthcare system focus on managing your pain. We are trying to heal. And we definitely success. We have a lot of people who recovered from chronic pain, completely recovered from chronic pain. Okay, so we run several studies to validate our approach. And this is one of the studies that we run in Ukraine. We run RCT in collaboration with Professor Dmitriev, a local doctor. So we recruited people with chronic pain, and we assigned them to two groups: control group, who was kind of a waiting list group, who waited for a therapy, and PDSR group, who got the therapy. So yeah, I don't show you here comprehensive graphics. It's kind of a public lecture. So I just show you quickly the results. We saw really extensive reduction in pain, but not just pain. As you can see here, we see the reduction in PTSD levels, pain interference, basically how pain interfere our life, depression, and anxiety. And this is not a surprise because our approach is not focused on pain as a symptom. We are working about, with this all mental state processes of really depression and anxiety. Definitely, anxiety is a very important process here because pain and fear, they are two very connected processes. If you want to think about it, what's the evolutionary role of fear? It's also to alert us about the danger, right? So basically, fear and pain can find each other in the brain and just create a collaboration between them and to straighten the signal. And that's why we mostly focus on fear, actually, treating chronic pain. And yeah, here you can see some of qualitative feedback that we got from the people. They was really excited. For me, the most surprising thing was, I remember our first meeting in Zoom. And like all of us very experienced in Zoom from Corona. And this curve, how people drop from the Zoom meetings, right? After 30 minutes, right? And I was very surprised to see that at the end of the meeting, it was like 2 hours, no one left, no one. And for me, it was really like, for me, it gave me a lot of motivation. And hey, like, it sounds like it's really, people have a lot of interest about it. And at the end, of course, as you saw the numbers, we found that it's also clinically effective. So what's next? Today, we developed also trainings for professionals. So here we run training for Ukrainian psychologists that came to Haifa here. And we developed a lot of digital tools to help also physicians and psychologists and also patients to understand what chronic pain is. So in different languages. We also run interviews with recovered people. So this is one of the interviews. This woman was recovered from chronic pain, working with us. And of course, as I said, we run multiple trainings for professionals. And this is also, I thought I also show you another slide, but yeah, so today, actually, one of our biggest projects is here in Israel. We run a big RCT where we teach healthcare professionals with our approach, and we want to run a study testing the efficacy of this approach, kind of scaling it, and to see what's the efficacy of our approach when we teach other professionals. Yeah, and also just I want to mention that I also run some basic science studies. So here we use FNIRS So this is a kind of a cap. We can capture different brain waves through this technology. And basically, in this experiment, we found a signature of fibromyalgia, one of the most comprehensive chronic pain conditions. And we use actually a lot today digital health technologies like smartwatches and phone apps. So we develop ourselves those approaches, also web platforms to track and do some follow-up for chronic pain patients, really to understand more the triggers of chronic pain and comorbidities of chronic pain, especially with depression and anxiety. And for example, this is one of the examples, Pain Story project. It's called, this is a platform, painstory.science, where we capture the stories of people with chronic pain, and we analyze their voices, their facial expressions, and also the content of what they're saying about their pain to better understand what chronic pain is. Yeah, and yeah, so we hope together, working with healthcare systems, working with patients, we can develop better models, better clinical models to help people with chronic pain. And yeah, I think this is it. Thanks. So if you have any questions, I would love to answer.
On behalf of the audience and those watching on YouTube, thank you very much, Pavel. This is intriguing. I'm sure there's some questions. I certainly have a few. Would anybody want to ask either via the chat? Oh, there's already via the chat. So let me ask the first one via the chat, and people can follow up via the chat or say it out loud. So a question is, I was wondering, does chronic pain develop after extreme events, car crash, war, etc. only? Also, are there ways of detecting and deterring it before it manifests, chronic pain?
Yeah, it's a great question. So chronic pain is very complicated. So we don't have one reason how to get to the state of chronic pain. So definitely, like, this is kind of a very frequent paths. For example, we know statistics that around 60% of people who go through a surgery develop chronic pain. So this is disaster, right? But on the same way, I can say that you can develop chronic pain in completely different way. So not you, sorry, not you. Some people may develop chronic pain through different paths. So for example, we know that depression, just depression or anxiety may trigger chronic pain. This is also one of the paths. So definitely childhood trauma or different mental processes that definitely can trigger chronic pain, because if they put you on a state of the danger, right? And this state of the danger can be differently reflected in our brain. You know, like for me, chronic pain is a kind of PTSD. So classical PTSD reflected through, our mental symptoms, right? But, we know today that we have very strong connection between our brain and our body. And basically, there are many paths how this trauma can be reflected. By the way, this is not just pain. It could be different conditions related to eating, for example. Definitely. Anorexia, bulimia, many of them develop as a result of the trauma. And of course, allergies, by the way, allergies can be also a reflection of our trauma. So chronic pain is basically one of the kind of solutions, let's call it, right? Reflections of our trauma.
Gotcha. Thank you. Stephen has a question, maybe by voice. So go ahead, Stephen. Thank you.
Yes, I want to ask Pavel if there's an animal model for pain. Presumably animals don't necessarily live in the same, shall we say, social having meaning of pain. I have actually a project in which I need to assess the pain of injections. I'm wondering how you do that in an objective fashion, which might be useful for some procedures in hospital which are genuinely painful. And is there a biomarker for pain that we can use and to get an objective measure? I imagine also that could be useful for people with chronic pain to show them that, in fact, objectively, there's no reason for their pain, if you see what I'm saying?
Yeah. So, about your last sentence, I want to clarify, because I think it's important. We should be very careful when we say, objective pain. And, it's very easy to invalidate someone's pain. Okay. So basically, what I said right now, you can kind of generalize it and say, hey, pain, basically pain in the brain. And basically you say, hey, you just invented it, right? It's not real. And this is not what I wanted to say. Every pain is real. All this pain, nociplastic pain, is definitely a real, and we saw also neurophysiological signature of it. It's definitely a real pain. It's just different. It's different type of pain. And right, it doesn't have, kind of classical triggers in the body. That basically, this is not a classical evolutional process, when we put our finger in the fire or something like that, right? So regarding your question, this is complicated. So using animal model for me is complicated, specifically in this case, because we're talking here about very high social processes. It's very difficult to build kind of simulations or simplifications for animal model for them. Generally, I'm using very ecological models in my research, because for me, I was doing a lot of lab research, because it's very easy, to bring people to the lab, and, we have a lot of equipment to create pain stimuli. And it's very easy. You bring a person, you stimulate pain, and you measure brain responses, and definitely a lot of signatures of it, right? Signature of pain, acute pain, by the way, also signatures of chronic pain in the brain, using some other technologies. But the problem is here is a generalization afterwards. Because, I can give you also example, maybe even in another case, I have a friend, she's a cancer researcher. And, she's saying, we are using these models of kind of, when we want to develop a new treatment, right? We put cancer cells in the brain, for example, of the rats or mouse, right? And then we have control group, and then we see if a new treatment more effective for the treatment group versus control, right? What is the problem here? She's saying basically this cancer wasn't developed naturally in the brain, and it's completely different process. It's much easier to kill the cells than in the case of naturally developed cancer in the brain. And it's very difficult. That's why, many experiments that really, show very promising results in an animal model, but when you come to a real, real world experiments, they fail. So for me, we should be very careful here with animal models, using them. So maybe, I'm not saying 100% you can use it, but right now I don't see a good model that we can really use for animals. And that's why I'm running all my studies, even in clinics, because I also want to use it in a real life settings, clinical settings. So, the studies that I mentioned that we're doing right now, we are coming to clinics. And we put all our equipment in there, and that's how we work today.
Thank you, Pavel, and thank you, Stephen, for the question. There's another question, and that is, what is the difference between your method, PDSR, and the PRT method, that's pain reprocessing therapy?
Yeah, so great. So it sounds like someone who is familiar with this field, definitely. Basically, I would say this is the same family of therapeutic approaches. Our focus, we have a different focus. First of all, we started initially as a group therapy in a Zoom, so it's a different format. But we also have some differences in tools and dynamics. In our case, we are using coaching tools. We're using coaching tools, and it's more personalized approach. And it's not necessarily focused on just safety, working with a sensation of safety, perception of safety. PRT is also a really great approach, and it show very promising results, by the way. It's a great study that was published 2 years ago. Yeah, so it's mostly focused on fear awareness model, where we focus on the feeling of safety. So we more generalized and we use different tools. But basically, it's not like I'm kind of trying to say we are better or worse. So for me, if you have access to PRT, do PRT, definitely.
Thank you.
It's a good approach.
Okay, great. Yeah, they're obviously a specialist in the audience, so thanks. So I have a bit of a naive question, Pavel. So on the personal note of my children, one is and this is not about chronic pain. One is very active on pain, and the other I'm almost afraid that they are pain intolerant, right? Can get many cuts, etc., and no pain at all. The middle child is actually just kind of right. But anyway, is there a risk with your method and these methods in general that you will actually cancel out signals that are important signals where a biophysical phenomena is reported? You've obviously thought about this.
No. There's no risk. We never have seen anything kind of similar to this. Because we are teaching our brain. We are not trying to decrease sensitivity to any pain. We basically working on reprocessing our brain and removing the state. We are not trying to change sensitivity of our nociceptive receptors. We're working on the level of the brain interpretation. We're working with interpretation. So pain is interpretation of our brain, and here we can change this interpretation. And definitely, we are not changing sensitivity of nociceptive receptors in our body that basically react to mechanical or thermal damage.
Okay, thank you. And perhaps as a final question, also having to do with your career path, as part of the goals of this series is to connect Australian researchers with Israeli researchers. So two-part question you can maybe just answer together. So part one is just about your personal journey. Maybe when I met you when you were an undergrad student, and I've had to guess what you would do in the future, it would really be a researcher of one type or another, but of course I couldn't know it would be about pain. So why? That is one. The other part is you're obviously a highly trained statistician, and how does that interact with your day-to-day research and work?
Yeah, thanks, Yoni. So I was exposed to pain research first time during my PhD, but I was doing more kind of social stuff. So in my PhD, I found a new mechanism of social interaction between the brain of two people when one of them feel pain. And I researched a role of hand-holding in this process. And it was very, kind of interesting stuff, but it was not very clinically important. When I got to my postdoc in the US, I was exposed to opioid crisis in US, and it was really big. It was really impressed me. And I said, hey, it's really cool what I'm doing, but I do something more important, more clinically important. And and exactly at the same time, to our lab came two clinicians. Dr. Howard Schubiner and another therapist, Alan Gordon. And basically they say, hey, we have a new therapeutic approach. So let's test it. We are clinicians, we kind of, we not really know if it's really efficient. So, and we run a study. Another PhD student, Yoni Ashar, who he led this study. And this approach was exactly the PRT that we talked about. So that was the validation of PRT. So basically, I was exposed to validation of PRT, and that's how I was exposed to the whole area of pain therapy in this field. And that's where I started. So when I came back to Israel, I established my lab and I continued to develop and test different therapeutic approach. And we also developed our own approach, as I mentioned, with Yulia Zatulovsky. And that's what we are doing today. Regarding kind of my second hat, right, being a statistician, it definitely helps me. It definitely helps me, it's not just being a statistician. I had a lot of experience of consulting researchers from different fields. And it's definitely, I have this map of connecting different fields, and It definitely helps me to understand other fields and better develop novelty, kind of understanding different fields, and definitely, also statistical skills helps me in my research. I want to validate my approach. I know what to do, how to do it, and it's definitely a very important skill.
Wonderful. Well, thanks so much. On that note, let me actually steal the show from Pavel, and first of all, we'll thank him again for the incredible talk. It's lovely to see what your lab is doing, and it's very important work. So as this is the last seminar we're having in this series, let me just point everybody out to all you need to do is Google Australia-Israel Scholar Seminars. You'll see a collection, and of course, Pavel's talk will be on here too. You'll see a collection of roughly 25 talks spanning a variety of fields, science, general science, education, a lot of agriculture, engineering of various sorts, and talks that have been very popular, obviously deal with Jewish and Israeli history and language. So please head on there and help support these Australian-Israel connections. If you are a researcher that lives in the Australia-Israel connection, that is Israel, either an Israeli researcher or scholarly practitioner that wants to present further such talks, or a person in Australia that has collaborations or seeks collaborations with Israel and wants to engage in these talks, then please contact the organizers, as we'll be picking up probably towards the end of 2024. So thanks again, everybody.
Yoni, thank you very much for inviting me here, you and Joe. And it's really great series of seminars. Thank you very much.
Lovely.